Hello, everybody. Welcome. Thank you for being on this presentation. My name is Dr. Steve Tulius, and it's an absolute privilege to be sharing with you today. Please, if you have questions, please go ahead and put them in, and we'll get to them at the end of the presentation. I have a lot to cover. This is my third year presenting for Epilepsy Awareness Day. Fantastic organization, so thank you. Brad and the rest of the team for inviting me back. I'm gonna go ahead and share my screen. And can everyone hear me okay? Just make sure. Yep, okay, perfect. All right, and can you see my screen now? All right. So just a quick disclaimer, this presentation is offered for general information purposes and only is not to be relied upon as medical advice or for any diagnostic or treatment purposes, right? So now we have that out of the way, more about myself. As you can see from my picture here, this is pre-COVID. Now I have the COVID beard here. But this is me. I'm a pediatric and family chiropractor. I've been in practice 18 years. I lecture internationally in the chiropractic field, and also particular focus not only in epilepsy, but also autism. I'm the former Autism 1 pediatric chiropractic continuing education director, former vice president of the International Federation of Chiropractors and Organizations, and I'm highly involved in the profession to help get this message out to the public, because it's one that is far past its time due. The reason that we get the types of results that we do, and I'm going to be sharing lots of studies, lots of data, clinical data, scientific literature, but the primary reason that we see the types of changes that we do is that we have a different approach, and that's why I've been invited to speak. I have a different perspective, and that's what we're going to talk about today. We come with a salutogenic perspective, and a salutogenic perspective comes from this word salutogenesis, which means that we focus on factors that support human health and well-being rather than factors that cause disease. So my belief, and in asking and speaking to the public many times, is that I believe that the body's designed to be healthy and not sick. And that it's constantly striving to be well. And so if there's a challenge, if we find ourselves in less than optimal health, or we find ourselves in a disease state or some situation, then there must have been something that happened, some interference, some blockage, some issue that is stopping us from being at our optimal healthy state. So my focus is always not on treating disease, but on increasing the factors that contribute to health. And so that's what we're going to be talking about today. We may have sound on this. I'm going to bring my microphone down closer to my computer. If we don't have sound, if you can hear this, give me a thumbs up, okay? Once we hit play.
Hi, I'm Beth. I first met Dr. Steve at an Epilepsy Foundation meeting. My 3-year-old son has epilepsy, and we were looking for some alternative treatments. And we loved what Dr. Steve had to say. He gave a really good presentation, and when we came to visit him here at the office, it was just awesome. It was such an answer to prayer, and he is so good with the boys. I have 3 little boys, and every one of them just adores to come here, and they're really sad if they ever have to miss Dr. Steve. And we have seen so many changes in Liam since he's been coming. He went from having up to 60 seizures a day till the last month and a half, almost 2 months, he has been basically seizure free. So we are definitely proponents of chiropractic and with Dr. Steve.
So I know the volume was low. Were you able to hear that? So what if you weren't able to hear that? What Beth shared was that her child Liam became seizure free after 4 weeks of care, after having up to 60 seizures a day. And I actually just emailed Beth. They moved away, and I actually moved too. He is now 6 years seizure free when they were told that he would always have seizures. This was a medically intractable type of epilepsy where he wasn't responding to the medication. So I share that story in the beginning of all my talks because I know that when people hear about chiropractic and epilepsy, they're often wondering, well, what's the connection? How is that even possible? And I think it will be exceedingly clear after this presentation why it is we see these types of changes. But before we dive into that, this is a case series I'm working on. This is actual clinical cases from my practice over the last 7 years. And so there's 25 cases with a diagnosis of epileptic seizures. These weren't cases that I diagnosed. They were diagnosed by medical professionals through EEG and other means, MRI. And so of those 25, we had 9 cases that completely resolved. Seizures went away, 36% of the people. 11% had a 50 to 75% reduction. So 44%. 4 of those people had slight improvement, 10 to 25% reduction, and there was only 1 person with no change. So that's 80% of people had either significant or complete resolution. And this was all sorts of different types of seizures: grand mal, partial complex, atonic, absence seizures. And we also saw great results for individuals who had genetic situations, challenges such as DRAVET, Tay-Sachs disease, various genetic challenges. And so now we didn't see resolution in those cases, but we saw significant improvement in frequency and intensity of the seizures. In terms of the time frame for the resolution, then in those cases where it did resolve, we saw resolution in 2 cases at 3 weeks, 2 cases at 4 weeks, 1 case at 6 weeks, 1 at 8 weeks, 2 at 12 weeks, and then 1 at 32 weeks with an average of 10 weeks. So I share this in the beginning just to hope to open up our eyes and perspective of the possibility of what I'm actually talking about, because it has huge implications for you if you are suffering with seizures, or your family members and the many people throughout the world. So today's talk, we're going to look at this thing called epilepsy and seizures from a different perspective. Not a better perspective, just a different perspective. We're going to look at it from a functional perspective, okay? And look at it not as necessarily the brain as the problem, okay? Because that's what we're told, is that the brain is the primary challenge, right? The brain is the issue. And we're going to look at it from a structural perspective, okay? Because we know that structure always affects function. So we're going to talk about how are these two things intertwined. Okay, so just quickly, and you already know a lot of this, but 1 in 26 or 11 million people are affected by epilepsy in the United States. Epilepsy is the 4th most common neurological disorder. Actually 65 million people in the United States are worldwide are affected by epilepsy. Number of children in the US is 470,000. And 1 in 3, and this is an important number, 1 in 3 live with uncontrollable seizures because the treatment options don't work. So it's exceedingly important that we talk about alternative options for people when the traditional or strategies aren't working. 6 out of 10 people do not have a known cause of their epilepsy. So again, this is really important when we're looking at new and novel ideas. And according to the Epilepsy Foundation website, which those same statistics I just gave you came from, they say that the human brain is the source of human epilepsy. Well, from a salutogenic perspective and from my training and background as a chiropractor, I start to think of it a little bit differently, because I know that the brain can't work on its own. It doesn't work in a vacuum. You have to get input from your surroundings, from your environment, for the brain to respond to the needs of your external environment and your internal environment. Meaning, if you stepped on a tack, your brain wouldn't know if you stepped on a tack unless your sensory nerve endings in your foot sent messages all the way up through your leg and through your spinal cord to your brain, so that your brain could then make sense of that information and adapt to it. And so when we look at the brain from a functional perspective, we start to think of it this way. Well, what does the brain need to function? Okay, maybe the brain's maybe it's just not getting what it needs. Okay, so what does the brain need? Well, if we look at it from a car perspective, a car needs fuel, right? It needs brake fluid, it needs parts, it needs all these different things. So a brain, well, the fuel for a brain is glucose primarily, also other vitamins, nutrients, chemicals. And then it also needs to be able to, it needs fluids like cerebrospinal fluid, right, to flush the toxins out, the byproducts, the waste products. So that there's a whole system to flush the brain out of all those things, and also to nourish it and protect it. And how does it get those nutrients? And also the other thing it needs is oxygen, right? The brain uses 20% of your body's oxygen. Well, it gets it through the blood. So maybe we should start looking at, well, is the brain getting enough blood supply and cerebrospinal fluid supply? Is it getting enough nutrients? Is it getting enough oxygen? So from a functional perspective, we start to look at it this way, that the brain is not simply this organ that works independently, but just like if a light went out in your house, and in the whole room, all the lights are out, you wouldn't go around thinking, okay, all the lights just blew all at once. You would go to the source, you go to the circuit breaker box. And so taking a systems perspective, taking a step back and looking at the brain as maybe the brain isn't necessarily always the problem. I look at it this way too. I'm sure you've had this situation come up with your computer. If it gets frozen, it gets stuck. If it's too many programs, not enough memory, it becomes sluggish, and sometimes it freezes, right? Sometimes it just has to reboot. And so I look at seizures also as maybe the brain is trying to reboot. Maybe it can't handle all of this stress. It can't adapt to the situation internally and or externally. And so it goes into this seizure state where it's too much and it has to reboot. So what does the literature say when it comes to stress? Because I think this is a really important topic. Well, we know that based upon patient data that stress is a common trigger. It's often reported throughout the literature that patients state that stress is a trigger. Well, in several studies, I'm going to show you that's what they're finding too. They say in this particular study, this was in 2013, exposure to exogenous and endogenous stress mediators has been found to increase epileptic activity in the brain and trigger overt seizures, especially after repeated exposure. So the more stress that someone encountered, the more primed they became to that stress. In conclusion, stress is likely to exacerbate the susceptibility to epileptic seizures in a subgroup of individuals. Realizing they're finding that some individuals are impacted by stress more than others. And that's what this study found too. This was looking at cortisol levels. And this was in 2019. So this is a recent study. 45%, and this was a literature review. So they looked at all these different studies. They found that 45% of the 38 total studies found higher cortisol levels in epilepsy patients than in healthy controls. They also found that seizures were related to cortisol increases in 77% of those 38 studies. So they're finding higher levels of cortisol, which also was linked to seizure frequency. There was more frequency in the higher cortisol levels, and that people with epilepsy are showing a higher cortisol reactivity. So they're more reactive to it. And ultimately, they said the findings suggest that epilepsy could be considered a chronic stress model. The potential sensitizing role of accumulative seizures and issues for future research are discussed. And so this is something that we really should look at. Maybe the brain of certain individuals isn't able to handle stress as well as others. And there's actually a way to measure that. And we're going to talk a whole lot about that. Here's another study too, looking at more of stress and how here they're finding early life stress. And I've done topics on early life stress in regards to autism. But early life stress is a hot topic in the scientific world because they're finding early life stress primes people for pretty much every chronic disease you can imagine and mental, emotional challenges as well. And so they're finding the same with seizures. It says an increasing number of studies have shown that early life stress primes seizure occurrence and increases epileptogenesis. So early life stress is a predictor for seizures. They're finding that it contributes to it, and it makes sense why. Think of it this way. If you have early life stress, and that can come in many forms, whether it's physical traumas, emotional traumas, or chemical traumas, then that's going to prime your fight or flight response, your autonomic nervous system, which we're going to talk a lot about in a second. it primes it, gets it stuck in more of a fight or flight physiology. It gets it stuck in that state. Versus the other side, which is the parasympathetic side, which is the healing, resting, digesting state. If you're stuck in fight or flight sympathetic dominance, then you're not going to be able to respond to and adapt to life's many different demands, both internally in your body and externally. And so they're seeing a link there. And if we think of it this way, just think of all of us have a stress bucket. Okay, and arguably we're under more stress than ever before in our daily lives now. You have a stress bucket. Okay, now that stress bucket, it's like at the water park, you know, those buckets, if that fills up too much, it's going to eventually tip over and spill out. It can no longer handle that weight of all that water. And so with seizures, they see that there's this threshold too, you know, and this is why stress is a trigger. Because that stress, you know, one stressor may not do it, but then as it builds up and builds up, then it hits that threshold, and that's when a seizure would occur or some other challenge in the body. Now, there's a couple ways to look at that. Okay, now if stress is a trigger, well, you can go about it one way. This would be more of a pathological perspective where, well, we could try to stop it from raining. Of course, that's not, we can't stop it from raining, right? That's not going to happen. Or we might try to chemically change the ability of the brain to handle more stress. We might try to change the cortisol levels and manipulate those levels, or we can take a salutogenic approach. A salutogenic approach would look at it, well, okay, we all have a stress bucket. How is your stress bucket doing? Can we increase the size of that stress bucket? Can we make sure that it's secure and stable? And maybe with that extra stress, can we make sure that your body is able to adapt and then siphon it off to other areas so that your body can dissipate that stress and adapt most successfully to your environment, effectively increasing your threshold versus trying to limit exposure? It's a different perspective. So where does the spine come into all this? Well, it comes in to, you know, we have to start talking about the anatomy, especially this area right here. This is known as the cervical cranial junction. Okay, for the cervical, meaning the cervical spine, there's 7 vertebrae here, and then the cranial. Okay, the cranium, the base of the occiput bone. Okay, this junction of this bone here, the skull bone there, and these top 2 bones, the atlas bone and the axis bone. These 2 bones in the spine, except for the sacrum, are the only bones that have a special name. They're given a special name because they have extremely special functions. The axis bone is an axis. It allows for your atlas bone to rotate around it. Your atlas bone is very flat. It's very flat, and it is very flat for a specific reason. It's designed to allow for the greatest degree of motion. Unlike these other joints throughout the spine, which are more locked in place by these facet joints. They're more stable and more locked in place. And so the great thing about this structure is it's designed for mobility and function. However, it also is more susceptible to injuries and postural changes and stress and traumas. Now, we need to take a look at it, especially 2 other areas here. Number 1, your spinal cord travels through this area. Okay, your spinal cord is the information highway sending all the messages from your brain to your body and from your body to your brain. And we also have your vertebral artery. Okay, your vertebral artery actually is supplying 20% of the blood flow to your brain, to key areas like the brainstem, the cerebellum, and other parts of the brain itself. Now there's two main arteries that do this. Okay, one is the vertebral artery, which sends the 20%. The other is the internal carotid artery, which provides 80%. We'll talk about that in just a second. Now, this is a front view of the spine. You can see that vertebral artery travels up through the spine itself, through these openings right here. It's designed that way for protection. Okay, because it's vulnerable. So it's actually inside the bone itself for protection. Notice how it then wraps around up through this bone here, the atlas bone, and then it's going to wrap back around and it's going to go right. And this is a posterior view. This is a behind view. It's going to actually pierce this ligament. You have all these ligaments that help stabilize this region so it doesn't misalign too easily, and keeps it more stable. Now it's going to pierce that membrane, and then it's going to wrap through, and then it's going to come up through the foramen magnum, the hole in the skull. Now this is a cutaway view looking at some deeper ligamentous support. We're not going to cover all these ligaments. I just want to show you how intricate this area is, and some key things. This sac right here, spinal dura, this is where your spinal cord sits in. It actually is covered in this thing called the meninges, which covers the spinal cord. It protects it. It's filled with cerebral spinal fluid to keep it nourished, bring nutrients, take toxins out, and also keep it buoyant so it's not moving around too much. Now that meninges attaches all the way up and down through the spine, and it especially attaches in key areas in your upper neck and at the opening of that hole, the foramen magnum. Now that's important to understand, because if there's tension, torsions, decrease in the proper curvatures, the biomechanics of the spine, that's going to put tension in the entire meninges and create meningeal tension. Okay. Now this is a cutaway. This is a human, so you don't have to be squeamish about it, right? This shows where the brainstem is in this region, the cerebellum, but it shows you all the delicate nerve fibers, the spinal cord, the blood supply that's going to wrap around right here, the vertebral artery, the cerebral spinal fluid, and the venous, the blood flow coming from the veins back to the heart is all traveling through this region. We talked a little bit about this. I won't go deeply into this. The key things to look at here, the vertebral artery traveling up through the spine. It's going to join right here and become the basilar artery right here, and it's going to supply the spinal cord, the brain stem, and key areas of the brain itself. So does it make sense then, if there's a rotational injury, if there's a misalignment of the upper bones of the neck, that would then cause a potential issue with the blood flow and the cerebral spinal fluid flow? Well, let's take a look. Here's some data on seizures and blood flow in general. Then we're going to look at how the structure, malalignment of the spine actually interferes with the cerebral spinal fluid flow and the blood flow. So what they're finding, and there's a lot of data on this. A lot of the data is more so on what's happening during seizures, okay? Not as much before seizures. I'm more interested in what's happening before the seizure happens, in the resting periods in between, what they call the interictal times. During a seizure, they're finding that with convulsive seizures, that they see an increase in cerebral blood volume, while with absent seizures, there's a decrease, with a mild decrease or no change in the cerebral blood volume of the frontal cortex in this particular study, which makes sense. That with the convulsive seizures, there's lots of activity, that they would see an increase in blood flow, and with absent seizures, they're seeing a decrease. This was another study also looking at the cerebral blood flow, and what they were doing, they're measuring the middle cerebral artery. And they saw there was a significant decrease in that blood flow during spontaneous absent seizures. So same findings as the previous study. Now, what I thought was interesting here is it says that neurogenic control could also influence cerebral blood flow during these absent seizures, that these blood vessels in the brain are encircled by a dense network of sympathetic and parasympathetic nerve fibers, which open and close those vessels. That's how blood flow works, right? So the sympathetic nerves, the fight or flight nerves, and the parasympathetic, the resting, healing, digesting nerves, will cause constriction or opening of those blood vessels, allowing for blood flow to increase or decrease. So that's important, because we're finding, and I'm going to share in a second here, that there's major autonomic nervous system dysfunction associated with epilepsy and seizures. Okay, there's big dysfunctions happening, and that's why we're seeing things like vagus nerve stimulation and therapies and detection devices looking at things like heart rate variability, which we're going to talk about. So, this is some new data. Some of the other data I just shared was from previous years. This is some new data that I found. Now, in looking at they're looking at blood flow through using, it's called arterial spin labeling. It's a form of MRI. There was 19 patients with idiopathic generalized epilepsy and 19 age gender matched healthy controls. And what they found is that there's hypoperfusion, meaning not enough blood flow going to places like the thalamus, the upper midbrain, and the cerebellum. Where is that? Well, those are the same regions that get their blood flow from the vertebral artery. Okay. And so that's what they're finding in idiopathic generalized epilepsy in the resting state, not in the actual seizure state. Here's another study also looking at arterial spin labeling. This study had 12 patients with medically refractory temporal lobe epilepsy. So refractory meaning not responding to drug therapy, and 12 normal controls. What they found was that there was ipsilateral or same side hypoperfusion. Again, hypo meaning a less than. There was a significant decrease in blood flow to the same side that the seizure is happening on that in that temporal lobe. Okay, and they were seeing a increase on the opposite side. Overall, globally, these people had a decrease in normal blood flow versus the controls. So overall, decreased blood flow on the side of the seizure and a overall decrease in the entire brain. So another study, again, now they looked at two different imaging methods, 20 patients with refractory focal epilepsy, and they found that not only did they have hypoperfusion or not enough blood, but they also were not metabolizing enough glucose. So there was decreased glucose metabolism. So what do we talk about? What does the brain need? It needs oxygen, it needs fuel, glucose, and it needs it needs those things, right, to function. So in 18 out of the 20 patients, they found that these people had a decrease in both of those situations. And this is in the interictal period, or in the period when the seizure is not happening. And this is just another case, 38, and this was temporal epilepsy patients, 19 normal controls, much of the same findings. They're finding in the hippocampus, the thalamus. Again, these are areas that are getting blood supply from the vertebral artery, that forms the basilar artery. So they're finding a decrease in blood flow. And again, another one, I don't think we really need to harp on it, but there's plenty of evidence showing that there's not enough blood flow. There's a decrease in blood flow in these cases. So does it make sense that a malalignment of that vertebrae in that upper neck, the C1 and C2, those top two bones, could potentially decrease the blood flow? Certainly makes sense to me. And here's what the data is saying. Now, there aren't a ton of studies on this that are showing, these studies are being primarily done by either chiropractors, osteopaths, other people interested in biomechanics. Very few people are actually studying this cervical cranial junction, except for orthopedists, and they're usually studying it from an instability perspective from people, for people who have ligamentous problems, like rheumatoid arthritis and a few other Down syndrome. There's an instability in that region genetically in some cases. Now, what about all those people who have had trauma to this part of the spine, or through various stressors throughout life, postural changes, have developed misalignments, malalignments of these areas? Well, this particular doctor, Dr. Scott Rosa, if you want to learn more about this, Google Dr. Scott Rosa and follow his work. There's some YouTube videos and other from some conferences that he spoke at. He's doing some really cool research where he's looking at functional MRIs. A functional MRI is different than a traditional MRI in that a functional MRI is looking at the dynamic blood flow and cerebral spinal fluid flow. It can see the flow of fluids, whereas a traditional MRI is static. It's one moment in time. So here's what it says here. They found that rotary misalignments of C1 and C2, the top two bones, can impair the normal cerebral spinal fluid flow, as well as contributing to an insufficiency of blood flow of the vertebral basilar system, right? The vertebral artery and that basilar artery that are formed. Now, what it says here at the bottom says a loss of the cervical lordosis, which is we should normally have this C-shaped curve in our neck. Most of us lose that over time through injuries, through texting, through using computers, through all these things. Many people have a very straight spine. They've lost their cervical curve, or they even will have a reverse curve, which is worse. And so what they're finding is loss of the cervical lordosis may create traction on the spinal cord, resulting in a downward pulling of the brain and cranial elements. They're actually seeing where parts of the cerebellum will start to come into the foramen magnum, what they're calling an acquired cerebellar tonsillar ectopia, which is it's similar to like a Chiari malformation, where Chiari's malformation is when the cerebellum comes into the foramen magnum. Well, what they're saying is that this can interfere with the cerebral spinal fluid flow and blood flow. Okay, and if we look at some other data, some other studies, this was in 2015. This was in the Neurology Research International, Dr. Michael Flanagan. And this document is fully accessible online. You can read it for yourself. It's a phenomenal work. They said that malformations and misalignments of this craniocervical junction cause deformation and obstruction of blood and cerebral spinal fluid pathways and flow between the cranial vault, which is the cranium, and spinal canal that can result in faulty craniospinal hydrodynamics. What that means is it changes the pressure inside of the cranium and the spinal cord itself. This is a pressurized system. And if you start to interfere with the biomechanics, you interfere with the fluid dynamics of that system. And it says, and subsequent neurological and neurodegenerative disorders will then persist. There's a great book I have here called The Downside of Upright Posture, also written by Dr. Flanagan, and where he documents his life's work, looking at how these things can contribute to situations such as Alzheimer's, Parkinson's, and multiple sclerosis. These due to a chronic decrease in blood flow and or cerebral spinal fluid flow to the brain and the spinal cord. And further in that paper, I won't read the whole thing, what he said here, and he had multiple references. He pulled together tons of data that this craniospinal hydrodynamics issue can lead to things such as seizures, psychosis, schizophrenia, depression, and mania. Now, one thing I do want to mention here is that he said further studies using upright and sign MRI really should be used. Now, why is that important? Because, and I'll share with you in this, I'll go back to that slide. Actually, it's a little bit further. So I'll share with you now. So this is important because most MRIs are done while laying on your back. Why is that a problem? Because that is not functional. We don't typically lay on our backs all day. We are under the effects of gravity, and MRI of the brain and the cervical spine, the neck, will look quite different when it is under the effects of gravity. And I'll show you some why in a second in one particular case study. I bring up this particular case. This was a case in my office, this young lady. I bring this case up now in this portion because on the previous slide, he talked about how things like spondylosis, which is a degenerative condition in the spine, stenosis, narrowing of the spinal canal, and even scoliosis in the lower spine can affect the hydrodynamics of the cranium. It can interfere with the flow in the cranium. Well, I bring that up because this particular patient, she developed seizures soon after she had a low back injury while on a trampoline. She fell and hit the metal portion of it. She injured her back and she couldn't bend over and touch her toes. Her seizures started, I think, approximately 3 weeks later after that. And they were told that, no, it was just coincidental. Well, I don't think that's the case, because here's what we found, and the mother shares it here. She was having partial complex seizures. After the first visit, she had no seizures for an entire week. At 3 weeks, she had no seizures at all. And after the first adjustment of her spine, she was able to bend over and touch her toes. And so if you affect one area, especially in the sacrum and lower back, you can absolutely affect the upper cervical spine, the upper neck, and areas in the top region there. So how do we know that? Well, we do have data on that. Okay, we have data, especially on this upper region. This is also from Dr. Scott Rosa, who I'd mentioned. This is a book called The Craniocervical Syndrome and MRI. And what they found in this, now what they were doing, they were looking at the blood flow and cerebrospinal fluid flow coming up through the neck. And what they found, they did before and after imaging. Okay, so they found an individual, they found a misalignment of the upper neck, and they use what is called an image-guided adjustment procedure with an instrument, okay, to make an adjustment, to make a correction. And they actually saw some really cool things. They saw, you can see it on this image here. I'm going to blow it up in just a second. But what they concluded was that misalignments of the upper neck can affect or cause neural compromise, and or some may contribute to a cerebrospinal fluid flow obstruction, as well as arteriovenous compromise. So interfering with the cerebrospinal fluid flow and the blood flow. Here's that image I was telling you about. On the left, we have some key areas where you see the red arrows. Here we see some spinal stenosis. We see that there's some decreased signals. We don't see as much white in this region right here, right at the C2 portion. This is the C2 vertebrae, and then in the brain here, we don't, there's not much white signals. And then this is afterwards. You can see an increase in the signals showing increased fluid in these regions, and also in the same area. We see that improved cerebrospinal fluid flow after the correction of that malalignment. Here's some other MRI images here. We can see, and I know this might be difficult for a lot of people to understand or visualize, but with this red line, you can see this is looking at the spine from above. This is the C1, the top two bones. This line should be straight. This is a rotational misalignment. It's also known as a vertebral subluxation. That's a misalignment subluxation of that area. And then this is looking at the spine from behind. And this red line right here should be parallel. Okay, that means that there's a tilting of that C1 vertebrae right there. So we can see this on imaging. We can see it on X-ray. We can see it, and unfortunately, chiropractors and some osteopaths, but primarily chiropractors, are really the only healthcare professionals that are so highly concerned with this. Unfortunately, due to professional battles and outright attacks on my profession over the years, the truth and the results and this pathological situation, this structural anomaly, this biomechanical obstruction, has been ignored because of professional battles. And fortunately, that's changing tremendously. Otherwise, I wouldn't even be on this call right now. I wouldn't have been invited back for all these years. So it's time that we start to break down those barriers more and more and start to look at this. And many other radiologists, medical doctors, neurologists, orthopedics are all starting to look at this more and more, but it certainly is way under recognized at this point. This is a case study from Dr. Julie Hunt, and what she found, and this is what she found and why it's so important. And she says in this article, again, most standard MRI imaging does not properly observe the craniocervical region. It really should be either standing or seated. Axial brain image MRIs usually will terminate a slice or two under the skull base. They won't actually go down into the C1 and C2 region. And if it's of the neck region, then usually it's more at the C2 disc level. They're missing the C1. So oftentimes this craniocervical junction is missed. The other issue is that the slices of the MRIs, the space is usually 4 to 5 millimeters, right? As they're taking pictures, it's 4 to 5 millimeters. And that can miss things like the cerebellar tonsils, the parts of the cerebellum coming into the craniocervical junction, and also the ligaments, which are only 2 millimeters in diameter. So there should be a smaller, when viewing the cervical cranial junction, we should use a different standard for measuring this area. Now, this particular case, this is a woman with neck pain, headaches, and brain fog, and occasional dizziness. Now, this is why this is so important. This was a laying down MRI. You can see this red line right here. This is the foramen magnum. Also here, you can see these little parts. This is part of the cerebellum. That's not considered a Chiari malformation because it's not far enough down. However, if you look at what happens when the woman was upright, you can actually see that the cerebellum is further down. It actually does classify as a Chiari malformation. So on both of those images, you can see this is why it's so important, because under pressure, those structures, the brain is going to sink down, right? So one final image, I think I might have one more from her studies here. You can see this line here. This is an atlas rotation. That's a rotation of the atlas bone. This yellow line here, that's the internal jugular vein. You know, that opening, that hole should be larger. So that represents a potential compromise of the venous blood flow leaving the brain in that region. And then we have right here also an MRI of the, this is a C2 rotation. You can see this red line. It should be horizontal. You can see it's tilted there. So does it make sense why then these misalignments, you know, would potentially interfere with the blood flow and cerebrospinal fluid flow? Well, we've actually seen that. Here's another MRI on the left. This is a atlas misalignment. The top line is the occiput, the cranial bone that should be sitting nicely on top of the atlas. And then this is the atlas bone. They should be lining up, as you can see in this other view right here. So there's ways to monitor and measure this. So as I mentioned in the beginning, structure always affects function, right? So a vertebral subluxation is a misalignment, right? Chiropractors have been talking about this for over 125 years now. So we just had our 125th anniversary. It not only will cause interferences to the blood flow and cerebrospinal fluid flow, but it can also cause autonomic nervous system imbalances. So let's talk about that aspect of epilepsy. You know, this was, before we dive into that, this was a literature review. Now, we don't have a ton of literature on epilepsy and chiropractic. We don't have any double-blind placebo-controlled studies. Why don't we have those studies? Well, we're a self-funded profession. We don't receive grants and governmental funds. And so a large part of what I'm doing in here today is to reach out and bridge the gap with the scientific community and the public, the patients who want and need solutions so that we can do more research and we can start to expand the knowledge here. But this was a review of the literature. They found 17 reports of pediatric patients receiving chiropractic care. 14 of the 17 were on anticonvulsive medications that weren't working. Upper cervical care or upper neck chiropractic care to correct the vertebral subluxation was administered in 15 cases, and all of them reported positive outcomes. Okay, now when I did a search, and I'm putting together a case series and another literature review, that literature review is quite old. I found so far 31 different case studies around chiropractic helping individuals with seizures. So what other data do we have? We do have some limited data on subluxation and blood flow. There was a study of 20 healthy students. They're measuring the middle vertebral artery, which is right here on this image, using a transcranial Doppler ultrasound. They did see a significant change in the cerebral artery blood flow, this middle cerebral artery blood flow, after an adjustment of the neck. It did return to normal pretty soon after, but they did see a change on that. Now, this was a really cool study in the Journal of Human Hypertension in 2007. It actually did receive quite a bit of press. There was 50 patients with stage 1 hypertension in a double-blind placebo-controlled study. They did one adjustment of the atlas bone. They monitored, they found those that had subluxations, misalignments. They found that the one adjustment over an 8-week period had the same impact on the blood pressure as what it would take 2 drug combination therapies to achieve, right? Taking 2 different medications, what it would normally take. There's an average drop of 14 milligrams in systolic and 8 milligrams in diastolic blood pressure. So we know that there's changes in the fluid, in the blood flow and the fluid dynamics there. Now, I mentioned the autonomic nervous system. We know in epilepsy, this is an issue. This is why there's so much talk about vagus nerve stimulation. My question is epilepsy a symptom of dysautonomia? Dysautonomia is a big word for an imbalance in the autonomic nervous system. Okay, that system, that fight or flight versus resting, healing, and digesting system. Well, what we know is that in epilepsy, there's a tendency towards more of a fight or flight physiology. This is just a quick overview of your autonomic nervous system. That fight or flight physiology, that sympathetic response is there for survival, right? We've all experienced that. Well, what would happen if your body was staying stuck in that? It would start to break down, right? Because once the danger is gone, our body should go into the other side, which is the parasympathetic, the resting, healing, digesting, and development side of our nervous system. So a lot of people, not just individuals with seizures, but a lot of people living today are stuck in a high sympathetic dominant state. Some of the signs and symptoms, things from insomnia, irritability, anxiety, focus issues. But you can also have low parasympathetic. I'm not going to dive into that because just sheer time. I want to dive into what the data says about individuals with epilepsy. So the gold standard in healthcare for measuring your autonomic nervous system is heart rate variability. If you look up heart rate variability in any scientific search, you'll find over 30,000 different references. There's a tremendous amount of data on this. So heart rate variability is an indirect measurement of your autonomic nervous system, okay? And what heart rate variability is it's measuring the intervals between your heartbeat. It shouldn't be the same like a metronome. It should be variable. Well, what we found, if you have low variability, that means if your heartbeat is very similar, those intervals between beats, that means that your body is not able to adapt well to stress. It means you're stuck in more of a fight or flight physiology. And we see that in epilepsy. We also see it, and this is especially concerning because we see it connected to sudden unexpected death in individuals with epilepsy. So this is a really incredibly important topic. It's controlled by your vagus nerve. This is your vagus nerve. Your vagus nerve also comes from the Latin for wanderer because it's this long nerve and it's a cranial nerve. It originates from your upper neck area and then goes all the way down through your neck, right? And then goes down to the organs to keep them in active balance and homeostasis. Okay. Now there's a plethora of data on this. I'm not going to go into this, but we see low heart rate variability, meaning more fight or flight, less vagal tone, okay, more fight or flight physiology in a wide range of issues, from major depression to anxiety to autonomic issue dysfunction in rheumatoid arthritis, lupus, multiple sclerosis, Alzheimer's, chronic fatigue syndrome, fibromyalgia, Parkinson's. Why? This should make a lot of sense. Your autonomic nervous system is there for survival, fight or flight. The other side is for healing, resting, and digesting. It's for repair. If you're stuck in fight or flight, your body's breaking down and it will result in many different health concerns and challenges, particularly when it comes to epilepsy. And there's a lot of data on this now. The review of the literature shows that people with epilepsy, that these autonomic changes are happening before the seizure actually happens. Okay, we're seeing that there's differences in autonomic function, but even before the seizure occurs. This particular review of the literature, there was 39 studies. They found that individuals with epilepsy have lower high frequency values of HRV, heart rate variability, which means they are more in a fight or flight physiology. And that's what this study said. Of the whole review of the literature, that individuals with it says, we confirmed and extended the hypothesis of sympathovagal imbalance in epilepsy. Our findings highlight the importance of investigating autonomic function in patients with epilepsy in clinical practice. This should be the standard. Every single individual with seizures should be having their heart rate variability monitored. There are a lot of home devices to do this now. Lots of things you can wear on your wrist, and you can even help regulate your own heart rate variability through a lot of home devices. HeartMath, there's some other systems out there, but you can actually start to bring balance and increase the size of your own bucket, right? Through mind-body awareness. Now, here's another study, 26 patients with medically refractory temporal lobe epilepsy compared to controls with psychogenic non-epileptic seizures. Now, the people with the temporal lobe epilepsy actually had higher sympathetic system activation and reduced vagal tone. So their vagus nerve not working so well, it's sluggish. Their fight or flight system is overactive. And in children with refractory epilepsy, this study found that they have abnormalities of their autonomic nervous system. So again, it's just, there's a plethora of data. The final piece of information on this particular topic I wanted to share is that newborns with neonatal seizures have showed lower resting state heart rate variability compared to controls. This is extremely important, okay? Newborns are all subjected to the same event. They're being born, whether it's vaginally or through cesarean section. What is potential in every single birth? Birth trauma. Birth trauma is exceedingly common, and it's overlooked. Okay, it's not every single child having neonatal seizures, in my opinion, should be checked for malalignment of their craniocervical junction. That should be one of the key things. Okay, and they're finding that because what would put a child into a low resting heart rate variability, that if they are stressed. Okay, what would stress them out? Well, lots of things could stress them. If the mother was stressed throughout the pregnancy, if there was alcohol use, drug abuse, things like that, but also physical trauma. Okay, and it's exceedingly common. That's why I bring it up. So this particular paper, I just found this one. This is from 2019 from a conference proceeding. This was looking at cervical stabilization. So this was surgical fusion of the craniocervical junction. I would say that's pretty extreme. In most cases, that's not necessary, in my opinion. That's going to be more for people with true instability, where there is a true rupture of a ligament, or like in this image here, there's a dislocation of the vertebrae here. Now, this is what they said, though. They said autonomic nervous system dysfunction, or dysautonomia, is associated with craniocervical and atlantoaxial instability. It said there was significant improvement of autonomic symptoms once they corrected that imbalance. Once after the fusion, there was improvement in the autonomic symptoms of these individuals. Well, before we have to fuse the upper neck, well, maybe perhaps we should look at a conservative option. So these are 3 different papers from 3 different professions. Actually, one is from a chiropractic paper, one is an osteopathic journal, and one is the journal of Spine, an orthopedic journal. They were all looking at how adjustments of the upper neck affect the autonomic nervous system, and they were looking at heart rate variability. And what they found is that adjustments of the upper neck all have a parasympathetic effect, right? They brought about a resting, healing, digesting effect. They increased the heart rate variability. Why is that? Well, what travels through the neck? The vagus nerve. So again, before the, and I'm not saying there's not a time or place for it, but before a surgical fusion, or perhaps even an implantation of a device, perhaps we should look at the structure to make sure the structure is sound, and look at some conservative options to address it. This was another study. This was a review of the literature. 9 studies included, looking at various body therapies, osteopathic profession, chiropractic, physiotherapists. And what they found is that when an adjustment is made, manipulation is performed in the neck, that there's a parasympathetic effect. And they concluded it was due to activation of the vagus nerve. And this is just one more study, 800 references, extensive review. There's overwhelming evidence for a manual model positively impacting the autonomic nervous system. So individuals with autonomic dysfunction, body work is showing that it can potentially help them. So what are some of the ways this can be measured? Heart rate variability is one. This is another. This is paraspinal thermography. This is looking at skin temperatures along the spine on both sides. And they see that there's differences in skin temperature when there's a subluxation, okay? Now, this was a case report of an individual, 24-year-old female with grand mal seizures that started at age 18. They transitioned to absence seizures after Keppra and folic acid, and the seizures went down to once a month. She also, though, she had a history of chronic migraines and headaches several times a week, and also severe fatigue. This is very common in the history when I find these types of cases. She had difficulty focusing. She also had severe increased seizure frequency when exposed to extreme heat. This temperature reading right here, the red means extreme imbalance. This should be within 0.5 degrees from side to side. Wherever you see a bar, it means it was warmer on that side. The numbers are the degrees difference. 4 degrees imbalance is a massive imbalance. That's dysautonomia. That's an imbalance in the nervous system, meaning her body cannot regulate itself in that region. That tells us there's an issue there. Well, this was 6 months later. You see a little bit of difference, right? Now we don't see all these imbalances in the heat temperatures. She only had one absent seizure during the 6-month period. She had resolution of all the headaches and migraines. Her energy went through the roof. She was able to focus. She actually started school, and she no longer had any relapses when she was exposed to warmer temperatures. This was a case of a child with autism and epilepsy, up to 800 seizures per month. He was in massive fight or flight. In fact, you could see it in his eyes darting, lots of physiological outward signs of fight or flight physiology. His seizures decreased massively. They went down by up to 95%. They also are using CBD, and that was a part of it, I'm sure, as well. But the chiropractic was a huge part of the transformation. Now, take a look at the before picture of his neck. I didn't get this picture until later, but this is, and you can also see the bowing and the flat feet. That's all common with imbalances in the biomechanics. Also the effect, he was never smiling before, and that was a huge change as well. Here we see a child. When we add these lines, take a look at the markings and the positions of the earlobes, the imbalance in the upper neck, the shoulder heights, the winging of the scapula, the rotation of the pelvis. This is common when there's spinal structural imbalances, when there's subluxations in the spine. I know my time is getting close here, so I'm gonna just run through these quickly. They're doing functional MRI studies. They're doing positron emission tomography studies now too. They're seeing changes in glucose metabolism after adjustments of the neck, meaning that the brain is working more efficiently in this particular study after an adjustment of the upper neck. This study found that the prefrontal cortex was working up to 20% more. The activity increased by 20% after an adjustment, one adjustment in the spine, in the upper neck here. So we know that the adjusting the spine impacts the blood flow, the cerebrospinal fluid flow. It impacts the neurology. It should come as no surprise that we're seeing some really incredible changes. Like for this child, came to me when he was 5 years old, 15 to 20 grand mal seizures, and absent seizures per day. Frequency started to go down pretty quickly, and then he's now been seizure free for 4 years. I do always like to state this. I started with a salutogenic perspective. My goal when taking care of people, and chiropractor's goal, is not to treat epilepsy or treat any condition that someone presents to our office with. Our goal is to assess normal biomechanics and physiology from a functional perspective, making sure that the nervous system isn't stressed, that you're not stuck in a fight or flight physiology, and then removing interferences and allowing the body then to do what it's designed to do. Here's the thing, we don't have side effects, we have side benefits. This was a review of the literature. They found that people with no symptoms at all, people under wellness care, having their spine checked and maintained, had improvements in everything from autonomic function to neurocognitive function, visual acuity, muscle strength, heart rate variability, all these things improved. Simply because we are increasing the body's adaptability. Just another case, this was a child who had massive changes. Not only did her seizures go down, but her vocabulary, her coordination, sleep, all improved. It was a massive shift for her. And I'll just finish off with this 32-year-old female, incredible change, massive stress on her surface EMG, which is another test lots of chiropractors use, chronic history of migraines. Her seizures started in the second trimester, just out of the blue. And after her first adjustment, her seizures stopped and they never came back. This was 6 months later, her surface EMG. The black bars previously indicate massive stress. Red is severe, black is extreme. This was thermography, 12 degrees warm on the right side of her neck, intense. This was later 2.4 degrees. That was 6 months later. And, some of these were already in my previous presentation. You can check that from last year as well. I included all of these. I'll just end with this. This was, I shared this at the end of my presentation last year. This was Elliot. His parents were at the presentation last year. At that point of that presentation, he had been 25 days seizure free after having 10 to 20 seizures a day for the past, I think it was 3 to 6 months. I'm happy to report he is now just past a year of seizure free. Since that point, he hasn't had any more seizures. He's been doing phenomenally well. And then when I shared this on my social media that I was going to be speaking at this event, I actually had two parents that had come to my presentation last year who said that from the referrals that we gave them, this parent also, their child's now been 11 months seizure free from the care they've received. And this other parent, their child's now 5 months seizure free. So my final thoughts are how to find a provider. Not all chiropractors focus on the upper cervical spine, and not all focus on subluxations or misalignments. There's some that focus on car accidents, nutrition, functional medicine, things like that. So you want to find someone, their website should talk about vertebral subluxation. They should do some form of objective testing, HRV, surface EMG, thermography, and or X-ray should be involved at some point. They should have more experience seeing more difficult cases. And if it's a pediatric case, they should have additional training and expertise in that area. These websites are areas you can go to find more information. And if you need and would like me to help you find someone, if you're not in the San Diego area where our offices are located, I'm more than happy to help find a referral. Just contact me at our Facebook page, Center for Health and Human Potential, or at this email address right here. Thanks so much. I don't know if I have time for questions. I'll let the staff let me know that. If not, I'm more than happy to interact with you on my Facebook page. Please, if I can help in any way, I'd be more than happy to do so. And do we have any questions or in the chat at all? If so, let me know. If not, I will bid you farewell. And again, please reach out, and God bless. And I hope that each and every one of you see amazing transformations, improvements in your health and quality of life, and have a wonderful rest of your day. Take care.